Hello, and thank you for listening to my presentation. My name is Robert Dima. I am a diagnostic medical sonographer at McMaster Children's Hospital in Ontario and a PhD candidate at Western University at the time of this recording. Today I will be sharing with you the results of a pilot study that we've done at McMaster Hospital, which was a retrospective chart review project on our acute appendicitis ultrasound protocol. Acute appendicitis is the most common surgical emergency in the pediatric abdomen. We see hundreds of cases every year at our site, which is a pediatric center. And the number of cases we see do grow year by year. Many of these patients receive ultrasound as a frontline diagnostic procedure, but the way that we scan these children today is very different from its first use. Today we tend to scan the entire abdomen and pelvis as opposed to a focal ultrasound of the appendix. These longer scans, paired with increasing prevalence over time, have likely had an effect on wait times in the ER and the financial burden that we see on the Canadian healthcare system today. As a result, we believe there is an urgent need to critically evaluate whether the therapeutic yield of the full abdominopelvic protocol justifies the use of exhaustive imaging over a focused appendix-only exam. So we wanted to see whether alternative ultrasound findings from the full abdominopelvic protocol, and alternative findings here refers to any findings on the ultrasound outside of the appendix, had any effect on patient management in the ER. The thought being that if what we're seeing in the abdomen or pelvis doesn't affect clinician decision making, then why are we recording it? As a result, our primary outcome was the proportion of cases with alternative sonographic findings that coincided with the deviation from standard care in the ER. That's demonstrated by this Venn diagram here. So we performed a retrospective chart review of all children who received a full abdominopelvic ultrasound scan to rule out appendicitis over a year's time from 2018 to 2019. We excluded adult cases, and also we excluded cases where there were other clinical concerns other than appendicitis indicated on the requisition. The rationale for excluding cases for multiple clinical concerns is that these patients would likely have undergone a full abdominopelvic ultrasound anyway. The study was ethically approved by the Hamilton Integrated Research Ethics Board, and a waiver of informed consent was obtained. We queried our radiology information system for all ER requested abdominopelvic ultrasounds performed during the pre-specified time frame. This turned 1,648 records. One reviewer applied the exclusion criteria to the cases by manual review of the requisition, and this excluded 1,125 records. You can see the reasons for exclusion on the right-hand side there. After application of the exclusion criteria, 523 records remained, and this number represents the number of ultrasounds requested through the ER for ruling out appendicitis over a year's time at our site. For logistical reasons, keeping in mind that this was a pilot study, we reviewed 230 of these 523 records. The reason that most of the cases were of male children, you can see 76% there are male, is that many girls sent for imaging to rule out acute appendicitis are also requested to rule out ovarian torsion, and this falls under our exclusion criteria for multiple clinical concerns. 61% of reviewed cases had ultrasound findings outside of the appendix, and of those, 13% were accompanied by a change in patient management in the ER. So within our sample of 230 records, 8% of children sent for abdominopelvic ultrasound to rule out appendicitis will have extra appendiceal ultrasound findings that are accompanied by a change in ER management. Shown here are examples of that 8% of cases in which the alternative ultrasound findings coincided with a change in ER management. Most often, these alternative findings were in the liver, either reporting periportal cuffing, thought to be a nonspecific indicator of abdominal inflammation, or increased echogenicity of the liver parenchyma. Those are some very common alternative findings that we saw in our sample. Other common findings outside the appendix included lymph nodes around the umbilicus, fluid-filled loops of bowel, and mild renal pelvic dilatation. We did have a few secondary outcomes, which we report here. The appendix was definitively identified, whether it was positive or negative, in 62% of cases. The average scan time for the full abdominopelvic protocol was 28 minutes, and our technologist only commented on the presence or absence of right lower quadrant pain by probe pressure in less than 1/3 of cases. So what did we find? It likely won't be any surprise to sonographers and radiologists listening that anatomical variants of normal and alternative findings are very commonly detected in ultrasound, and importantly, they are included in the final report that is sent to the clinician. However, most of these findings are likely very low impact, as only 8% of cases had alternative findings associated with a change in management in the ER. Our study had several strengths as well as limitations. I want to emphasize the fact that we only report here the proportion of cases in which alternative ultrasound findings coincide with changes in ER management, and whether or not the change in ER management was brought about by the imaging findings is left up to the interpretation of the reader. For example, one case had an alternative finding of periportal cuffing in the liver, and the associated change with management was a discharge diagnosis of UTI. This pilot study was an essential first step in the process of determining the true value of the abdominopelvic ultrasound for this patient population. Higher level evidence can be obtained through prospective trials, evaluating a full versus a limited protocol for pediatric patients with suspicion of acute appendicitis. Thank you very much for listening. My contact information is listed, and I'd like to also acknowledge my co-investigators and others at McMaster Hospital that made this endeavor possible. Thanks.